Final speaker for today, Dr. Paul Randhawa, one of my neurosurgery colleagues here locally at Honolulu, Hawaii, at the Queens Medical Center. He'll speak on the contemporary treatment of cervical myelopathy.
Yeah, thank you, Kyle, and thank you to the course faculty for the opportunity to talk today. Paul Randhawa, I'm one of the neurosurgeons here on the island at Queens Health Center. Welcome. Please do enjoy your stay, but do keep in mind that if you want to have epic fun, I'm on call Saturday, so hope not to meet you in the emergency room. Well, today I have the honor of speaking to you about this topic. It's a really rich topic which we can easily spend hours, if not days, talking about, but my goal is over the next 20 minutes just to give you a simple, brief overview or a big picture view of this topic. So no disclosures or conflicts of interest. So we'll start with a little background. We'll talk a little bit about natural history, the etiology of this, important differential diagnoses to keep in mind so you can keep the lawyers away. The workup, when and how to treat this. When is it appropriate for ventral versus dorsal approaches or a combination of approaches? We'll close it up with some special considerations when looking at this patient population. So when looking at this disease process, I think it's always helpful to have a handful of questions in the back of your mind. What's the pathology? What am I dealing with? Where is this pathology? Is it in the front of the spine? Is it in the back? Is it both? And what's the time course of the symptoms for the patient? Is this happening sort of fast or is it happening slow? Sort of dictates how much time you have to treat the patient. Is the patient resilient? Are they robust? Are they frail? I think Dr. Clark should have hit on the topic of frailty. And last is, again, ventral or dorsal or combined approaches to treat the spine. So just basic definition, it's some sort of disease process here where there's just progressive compression of the cervical spinal cord causing a functional impairment. It's important because it's one of the most common causes of spinal cord impairment. And with our ever-growing elderly population, it's becoming a more and more significant burden of disability for society, and a lot of money goes into this. And the pathology, just to keep it simple, it's a combination of either static or dynamic factors that result in ischemia, inflammation, and apoptosis. So the natural history, as we know, typically is mixed, but it's generally a slow, stepwise deterioration. There may be periods where the patient does fine and it's like, hey, I don't think I want to have anything done. Acute deteriorations are less common. But I think an important point to keep in mind for ourselves and for our patients is, if there's long-standing stenosis or some symptoms, the chance of recovery decreases with time as we have demyelination set in place, as the samurai sort of shows. Etiologies can be many. A definitive list is here where, you have disc osteophyte complexes, facet hypertrophy, thickened ligamentum flavum, deformity, developing kyphosis is another. Dynamic disease processes such as subluxations with neck motion on flexion or extension, OPLL, trauma, tumor infections, and congenital spinal stenosis. Here's a nice diagram just to illustrate that, hopefully an easier way to assimilate that information. Again, disease from the front, or from behind. This is just a big picture view of the pathology. Again, you have your static processes such as ossification of the posterior longitudinal ligament or a disc osteophyte complex. You can also have your dynamic factors. Maybe there's some ligament laxity and the patient's sublux on flexion or extension. Ultimately, you get some sort of compression, you get the ischemia, you get the neuroinflammation, and then the apoptosis. As far as how to work it up, this is sort of a big picture, bird's eye view. It always starts with a good history and physical. This is where you watch out. This will help you sort of weed out those differential diagnoses, which I'll get to next. And then you use your imaging and other modalities to help drive in the diagnosis. And then you determine, are they symptomatic or are they not symptomatic? And that'll sort of drive what you do next. Do you treat or do you watch and observe? So differentials. The big clue here for the students and residents is, if your sensory and motor symptoms just don't seem to match up with the imaging, start thinking of other things. A common board question is, like patients with ALS, they're weak. They may have findings on MRI, especially if they're older, but they typically don't have sensory deficits, although they'll have fasciculations, weakness out of proportion to what you see on the MRI. Others could be peripheral nerve entrapments, median neuropathy, ulnar neuropathy. Here's a more definitive list. You can also think about demyelinating diseases such as multiple sclerosis, neuromyelitis optica, neoplasms, spinal vascular malformations, infectious processes, and hereditary spinal diseases. When you're evaluating them with the physical exam, and also getting a history, history or findings of gait instability and loss of balance, inability to manipulate small objects, and difficulty or loss with hand dexterity, such as buttoning buttons on your shirt or dropping objects from your hand, weakness, and bowel bladder dysfunction. Specific signs, you're looking for long track signs such as Clonus, Babinski, Hoffman's, Romberg's, and Lermite's sign. Imaging, next step. Most commonly, MRI is probably the most common imaging modality to help us drive in a diagnosis in addition to the physical exam. But x-rays have a role too, especially if the patient, while lying down, seems to line up, but then when you flex or extend them, there's a lot more motion where you maybe get a 50% slip of a vertebral body. CT helps you with the bony anatomy. Is there maybe a chronic old fracture that the MRI doesn't pick up well? And then in unique patient populations, you may not be able to get an MRI, but you have to rely on a CT myelogram. These would be patients with pacemakers or spinal cord stimulators that aren't compatible, patients with left ventricular assist devices, or other contraindications. When to treat. So I'm going to go to, there's a nice review article that has a clinical practice guidelines from the AO Spine, North American Cervical Spine Research Society. And just to make it simple, if you use a scale such as the MJOA, if you have a patient who is moderate to severe symptoms from cervical myelopathy, I think it's generally pretty clear to offer an intervention. There's a strong recommendation with good evidence. Now, if they're mildly symptomatic, that's where things start to get in a gray zone, and I think a lot of it depends on the patient's health, the risk-benefit ratios, your comfort level, and the patient's comfort level. And lastly, if they're not really symptomatic, but they do have stenosis, then there's debate of, hey, is there time to just watch, educate, and optimize versus do you prophylactically operate? And that's a topic that generates a lot of debate, but at least in this diagram, they recommend not operating. So conservative treatment can be appropriate in certain circumstances. Again, it depends on how healthy or frail your patient is. Generally, it's someone to at least keep a close eye on. As we know, the disease process is one that is generally progressive over time. Looking at the literature, some studies say that patients, 20 to 60% of them, are going to have some sort of progression over time if left untreated. So unless they're near the end of their projected lifespan, generally worth talking about treatment. Another study, a systematic review, showed that there's little evidence to support non-operative management with those with moderate or severe cervical myelopathy. So what are the surgical treatment options? Here's a nice diagram. You can go from the front. These can include anterior cervical discectomy infusions or corpectomies, cervical disc arthroplasty, although one caveat with that is if you have a patient with congenital cervical canal, maybe not the best idea, but again, up to the provider's decision. You also have your posterior approaches such as laminoplasty, laminectomy with fusion, and in some roles maybe laminectomies, but you need to watch out for a delayed onset of kyphosis over time. And then you can have your combined approaches going from the front and the back. The approaches from going from the front, if you have a kyphotic deformity, it's easier to fix. You can address the pathology, especially if it's from the front. You can be direct about it. You can get a fair bit more distraction, and sometimes that allows you to deal with posterior pathology as well, such as buckling of the ligamentum flavum. And it's typically better tolerated when it's 1 or 2 levels of disease from the front and in younger patients. But the disadvantages are, risk of a cranial nerve injury or palsy, dysphagia, dysphonia, and a greater risk of vascular injury, in particular with the carotids, although the vertebrals are also at risk. And if you go more than 2 levels, I think one of our previous speakers, Dr. Tay, might have mentioned, as the more levels you have, you start to have to worry about pseudoarthrosis. Then there's a debate of do you go ahead and add a posterior construct to make it more rigid and help with the fusion. Now, dorsal approaches, technically they say it's easier for neurosurgeons, but I guess it depends, or spine surgeons, but it just depends. Virtually no risk to the cranial nerves or the carotids. unless you're, I think, at C1 or 2 and your screws go past the front of the vertebral bodies. It's also great for professional singers and not getting sued by them for losing their voice. And a lower risk of incidental durotomy. You also have a wider exposure, and if you have one, you can fix it easier. The disadvantages are if you don't fuse, you have a risk of kyphotic deformities. If the pathology is in the front, it's harder to address it. You get an indirect decompression. Some patients tend to have more chronic long-term pain from this. You also have to worry about a higher rate of a C5 nerve root palsy. So the next question is, so do we go from the front or the back? And how do those patients do? I think one paper that's been very helpful to sort of just use as a reference is this one from JAMA, which is a randomized clinical trial titled The Effect of Ventral versus Dorsal Spinal Surgery on Patients' Reported Physical Functioning in Patients with Cervical Myelopathy. So the study design is great in the sense that it's prospective, it's randomized in a clinical trial. The patients were aged around 45 to 80, typically, that's where we see most of the myelopathy. It involved 15 hospitals in North America, I think 14 in the US, 1 in Canada, but a lot of hospitals. The enrollment period is a nice 4-year window with good follow-up after that. The inclusion criteria, we talked about the age, but basically for cervical myelopathy, it's defined as having 2 or more of the following signs or symptoms, clumsy hands, gait disturbance, hyperreflexia, Babinski, bowel bladder dysfunction, ankle clonus, and radiographically 2 or more levels of compression between C3 and C7, as shown on an MRI or CT myelogram. The exclusion criteria include those patients that have kyphosis, or they have ossification of the posterior longitudinal ligament, or previous spinal surgery, or significant health conditions that sort of preclude them from having a safe surgery. Just a few lines on their radiologic image analysis. With this multiple sites, they had 15 expert spine surgeons, some of them who are speakers later on in this course. They determined clinical equipoise and suitability for these patients to be randomized to a ventral or posterior approach. Basically, a clinical equipoise was defined as not met with either 80% or more of the panel members choosing either ventral or dorsal surgery. A simple majority voted against randomization. So interventions, 63 patients underwent a ventral approach. There's an ACDF or dorsal approach, which were 100 patients, and that could be laminectomy with fusion or laminoplasty. The results, out of those 163 patients randomized, 155 had surgery and completed the trial at 1 year, and 80% at 2 years. If we look at benefit, the minimal clinical important difference, or the MCID, is 5 points or higher, and both groups achieved that, so similar. As far as complications, the overall complication rate was a little higher on the ventral side, but if you take a look, the dysphagia is probably the one key thing that's significant that really stood out. Otherwise, they're pretty similar. Although interestingly enough, another one is third-day readmissions, which was not really seen in the ventral group. So in summary, the outcome is that the ventral surgical approach did not significantly improve patient-reported physical functioning at 1 year when compared to dorsal approaches. So now I'll just take a few minutes to just focus on special considerations or unique patient populations. There are those patients with ossification of the posterior longitudinal ligament, and you can sort of see that on the images on the right side of the screen with an MRI and a CT. Also, patients with left ventricular assist devices also warrant special consideration, and those patients that are at risk for infectious etiologies, whether immunocompromised, transplant patients, diabetics, IV drug users, et cetera. So OPLL, this is just one of my first patients that presented in clinic was this, and when I factor in all my years of residency, fellowship, and my prior job before coming here, I'd only seen maybe like 3 patients with significant OPLL. But here's one where it's pretty extensive, and it actually goes all the way down to about T10. They're don't have cervical myelopathy, they actually have thoracic, but I thought it was an interesting picture just to show. As far as treatment for OPLL, you can go from the front or the back. When it's going from the front, it depends how focal it is and your comfort level, the patient's comfort level, but that can be an ACDF or a corpectomy. Some special considerations are because of that OPLL for our students, it tends to be very adherent to the dura. You worry about cerebrospinal fluid leaks. So folks will thin the calcification with a burr and try to lift it off with microcurettes and kerosins. Then they'll try to fill up the space. But there are times where the calcification will just not come off, but you do need to get some sort of decompression of the spinal cord. And this is where they advocate leaving a free floating island of calcification. And you can sort of see that on the picture on the right. There's also posterior approaches to OPLL, like that picture I showed just a few moments ago. With such diffuse disease from the front, probably leaves just a posterior approach to the patient when it's time and when they're ready for surgery. You can also do combined approaches, just depends on how much you need to do. The literature talks about treatment algorithms for these patients. If it's a single or double or 2 levels of OPLL, some authors recommend an anterior approach. If it's more than that, they typically recommend a combined front or back or just posterior approach. So here's another special consideration case, just that tones in on paying special attention to the history of the patient. So I got called about a 68-year-old female patient they claimed it was myelopathic. Get the call at 2 a.m. while I'm doing a craniotomy for subdural. And the ER just leaves a message for the team saying, hey, we just want you to see him in clinic. It's just a myelopath with neck pain, but we took an x-ray, let us know what you think. After finishing the case, I'd take a look at the EMR real quick and, I noticed multiple ER visits with progressive weakness and multiple mentions of IV drug use, patient coming in with fentanyl overdoses. You take a look at the films, you're like, oh, they're kyphotic, but maybe something more is going on here. And in this case, infection. But on further review, the patient's actually gotten progressively weaker in the past few days. So we bring them in through the ER, intra-island, get a CAT scan, and it's actually much more worrisome than you think, followed by an MRI. And at this point, on arrival, the patient's just got elbow flexion, but nothing below that. And so we emergently rush them to the operating room, and they end up being a front-back approach, corpectomy from the front, and then stabilization from behind. Case 2, this will be with the left ventricular assist device patients. As we know, heart disease continues to rise in our country. And for this patient, this is when I was practicing in sort of the heartland of America, which is also where the highest density of heart disease is. And a lot of these patients will develop pretty bad heart failure, and these left ventricular assist devices buy them more time until they can potentially be candidates for heart transplants. But at the same time, they're immunosuppressed. They have, a line going out of their body, so they're high risk for infection. So for this patient, this was another one where you get a clinic referral, and they're like, hey, I got a myelopath for you, but I don't have the workup. Can I send them to you? And, I have the clinic call, and the patient actually tells our clinic, hey, I'm starting to lose function of my arms and legs in the past 3 or 4 days. So we have them come into the emergency room, similar story to the prior patient, get an emergent CT scan, and this is what we find. So it's actually not cervical myelopathy in the sense of a slow degenerative process, but once again, an infectious process that sort of mimics a myelopathy patient to those who aren't as familiar with spine. So we take him to the operating room, perform a front and then eventually a back procedure here. So multi-level corpectomy from the front, followed by stabilization in the back. And a few nuggets for those patients that you take who have a left ventricular assist device. If you're in an institution where these are put in a lot, talk to the cardiologist team about making sure it's the most up-to-date device, such as the HeartMate 3, because some of these devices, they say the patient can't really come off of anticoagulation. Some of them you can for about 3 or 4 days, and it makes all the difference in the world, especially when you're doing a corpectomy. And when you have to back up these patients or just do a posterior approach, one of the challenges that people can run into is when you lay them prone, if you have a chest pad like this, sort of horizontal, it will severely compromise the outflow of the assist device, and they have inadequate perfusion. And so the trick is to have your pads more in a vertical position like this, or to use a Wilson frame so that they don't become hypotensive and unstable when you're trying to work on the back of their neck. So in conclusion, myelopathy is generally a slow process. It's degenerative, as we talked about, but it's important to have a high suspicion for other etiologies. such as ALS or a subtle infectious process that can deteriorate rather quickly at some point. Let's see what else here. Generally, if they're symptomatic, most of the time we're going to recommend some sort of intervention unless the risk of surgery is too high. And again, ventral, dorsal, combined approaches are all appropriate. It depends on your comfort level, the disease process, and the patient's comfort level. And also just taking some extra consideration for those patients who have ossification of the posterior longitudinal ligament, those patients with left ventricular assist devices, or those that are at high risk for infection and can be mislabeled as myelopathic as opposed to the more urgent infectious process, which starts slow, then speeds up rather rapidly at the end. So these are my references. Thank you kindly for your attention.